Thank you very much. So what's happened in Christchurch? So we started this in Christchurch. We thought, right, we've just got to go ahead and do it. Like that sprint philosophy that was mentioned, let's get it going as soon as we can. We've had 20 to 30 so far. We have also had a meeting with a small group of interested GPs to explain how we're doing it. We're currently using the ASHM guidelines and adapted them for local use. And often they're seen first by nursing staff. This is because there is quite a lot to do, actually. There's just a point, even though you might repeat it, there's still quite a lot of points you knew, and they're seen first by nursing staff and then go through this pro forma and then seeing me or Heather or Megan. So we've got a little bit of a process, not as sophisticated as your process yet. And we also participated in New Zealand AIDS Foundation community meeting. And that was a chance for people to see us, see me, see other people, and from that we've had lots of people come forward and say, yes, we had a chat, and after that, or during the meeting and after the meeting, I'd chat to some people and say, yes, come along. So the major milestones, getting that consent form from MPS was crucial. This was the sticking point was saying, if you were doing it generic, that you were liable as a prescriber for the quality of the medication, which put people right off. So we had to go through MPS, lots of discussions. New Zealand AIDS Foundation, especially Joe, has been involved in getting all this going. And then the Truvada indication changed, and also myelin, one of the generics, has been approved for PrEP use. So first of all, we used the New South Wales guidelines, which you will recognise probably because these ones you were rolled out. And so that was, the ASHM had a dog's breakfast of commentary and stuff. The New South Wales guidelines I thought were the best in Australasia, to be honest. So we looked at those and adopted them. And then the Australasian Society, and I advise everyone to look very carefully at these. So these have been well thought out, well published. These are it, and these came through, I think, in June, July. So what we have done, and if you look here, this is some of the criteria that you use for MSM and for transgender, etc. So we've used these criteria loosely, but mainly the main people we want to do is they're having unprotected sex, they're at risk of getting HIV. It's a really good idea, if they're not going to use condoms, that they go on PrEP. So we'd identify those people and suggest that they go onto it. Now, if you go through the guidelines, the clinical assessment's very important, making sure that these are some of the criteria that they suggest, and making sure someone's not HIV positive. So I'll just bring out some of those points that you didn't want to be HIV positive when you came on board, and you couldn't use a point of care testing because it's not sensitive enough in terms of the window period. So we'd make sure we had a fourth generation test, and we'd want to start it as soon as possible, close to when they start it. Now, sometimes you can figure that with the person who's there. If they haven't had sex for 1 month, then it's obviously you can do it and off they go. Renal function, now the whole thing is greater creatinine loss is associated with these factors, less than 25, more than 40, estimated GFR less than 90, medications for diabetes, hypertension, and also with good adherence. And also in the guideline is quite good in terms of pointing out what sort of things we'd also think is we should be assessing risk factors for renal disease, hypertension, diabetes, concurrent medications, etc. So some of that's important to document before you start it. That's our opinion. And then a clear criteria of when you are not going to do it. If someone's got a GFR of less than 60, no. And then in terms of continuing monitoring, normally they would say you'd do it at 3 months and then every 6 months, but you'd have a look at it and do it more frequently if there are some risk factors. And these are the identified risk factors they push in the ASHM guidelines, so these are the ones we adopt. And they're so you need to look at their age and also take history, and so if they're steroid using, lots of creatinine protein, and their GFR is sort of lowish, like 70 or something, then you do it more often. And also there's the whole thing of bone density. So bone density is, I don't think, much of a problem, but there's a small decline. But you'd also want to make sure you identify those people who are at risk. If they're a little old man with not much weight on, prednisone 10 milligrams a day, you'd want to identify those people. And the question is, how do you do that? Most of the guidelines just say check out for osteoporosis. And you think, what does that mean? Do you go up to someone and say, have you got osteoporosis? Or not? What do you say? And they're very vague about this. So what we've adopted to do is use the FRAX score and just goes through those questions. And if you're less than 40, it adjusts you to age 40. But they're a very good list to do. And then, so bone density, that's the discussion about that. And some people might need to use other sort of measurements of that, but generally they won't. And then further testing that we would do is the other STIs, of course. Hepatitis B and C are mentioned in the guidelines, but we would include hepatitis A as they do in Auckland and other studies because it's in all the guidelines and it seems very sensible. Other guidelines mention metabolic screening. They don't mention this in the ASHM guidelines, but I think if you're going to screen for diabetes, how are you going to do that? Well, I think you should do HbA1c and glucose. And also, I think you should include liver function tests. They're not in those guidelines because of the risk factor, the renal risk factor. This is a sample of when you should do the tests and which ones. So we've added a few more as I've discussed. And you'd also adjust that one about the renal function test depending upon what their history and findings are. You also need to go through an informed consent of all these items. If you go through the guidelines, you're going to do it well, you need to give this information. And obviously there's quite a lot, and that's why it's such a good idea to have someone do it in a group, and you can actually say, yes, I've covered this. At the moment, we don't have that group, but I think it's a great idea. So we do have to cover those items off. And we'd obviously prescribe generic Truvada at this stage. So what do we actually do? Well, here's our lovely, where is Keith? Is Keith here? No, the lovely Keith. He's done a lot of work in this, and Christine, our nurse, you might have seen her, she's put it all to, so there's prep packs in this thing. So when someone comes in, and this will be mainly through the nursing clinics who will say, yes, they're interested, or we will refer them for that, yes, and they will get it out. The first page, if you can see that, says, please do not take any page out of the ready-made prep packs. 999, if you do, which is mainly for me, I think. And in here you can see the prep pack is the New Zealand AIDS Foundation thing, which is very good, so people can just read it and go through it. And then there's other information there as about what HIV, which is from the CDC actually, and then that consent form. And so then and this is when they see me or another clinician, this is a form that we can write in, and it goes through customs so it doesn't come back. Otherwise, if they import it, sometimes they'll hold them up at customs and they'll send us and I have to fax it back. It's a real, or if you do it at the start, they go through smoothly. So I've learnt experience on that one. So this is, you can see this vaguely, but this is what we do. So we've got a medtech system, and we have a pro forma which lists all of this, and so the nurse will go through that and go through answer, yes, 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 we've answered those questions. So it's quite a lot of work, but once it's done, and we can be sure of it. And then we order those bloods, and you just cut and paste into a sample, and then the STI screen and the urine analysis, and consent documents, yes, I've given these documents. So they go away and do it, done, come back a week later, and this is when they would see me, and I would do the first, and this is our prep 2 visits, and we've got follow-up, and then 30 days, 3 months, etc. And then I go through those and saying, yes, I've done this, they know what they're doing. I also go through. We just keep adding them, unfortunately, or it's a good idea. Discuss the letter to the GP, and I dictate a letter then and there in front of them to their GP, and now we've just got a form that we just do it. If they consent to this, it also goes on Health Connect South, so the GP knows with their consent this is what they're on, and go through some of these points, and I go through drug interactions and demonstrate about Voltaren and how it doesn't work so well on New Zealand formulary, and do it with them there and go through these things. So that's how we discuss how to order it online, go to Ending HIV thing and say things change constantly. And these are some useful links. So it's explaining that it's very good to go online, go through that, and I used to have stuff on dynamics and say this is the one to do. That's changed. It's probably Green Cross now. So I say, go to one spot and you can get it from there. So far, as I said, we've got 20 to 30. It's a group activity done through the whole clinic, basically, which is the only way we've managed to not sort of get swamped. And anyone can, we change these documents, but if anyone wants them, they can contact me, and that's it. I think I've got, and I'd also, I don't have an acknowledgement slide, but I'd particularly like to acknowledge the staff at Sexual Health who've really got behind this to help, and also the New Zealand AIDS Foundation, and particularly Joe, for all this work that makes this possible, because it is a linked up thing and not in isolation, so we can draw from the experience what's happening in Auckland, and all this documentation and stuff that happens, we couldn't just do it by ourselves. So it's really nice to be part of a whole team. And I think we need to do this if we're ending HIV, and we have to make it happen and engage support. But it is important that we start and get the ball rolling, which we have done. Thank you.
Thank you.
So, I think your strategy was very closely linked to our ending HIV strategy in New South Wales, which really, you know, the test often, treat early, and prevent leading to the goal of ending HIV and virtually eliminating HIV transmission in New South Wales by 2020. So clearly a very ambitious goal, but it's really we felt it was essential to have a strategy with such an ambitious goal. So what were we doing well in New South Wales? Well, we had a good HIV care diagnosis cascade. So the 90-90-90 WHO targets, we had 90% of people in 2015 diagnosed with HIV. We were doing not so well, but not so far off 90 on people who were on treatment, and we were over 90% of people who were on treatment who had a suppressed viral load. The other thing we were doing well was increasing annual testing frequencies, which is another key component of the strategy. So you can see here at the very top, kind of lighter pink or orange bars, that they indicate those people who were reporting 3 or more HIV tests in the previous year, and that had increased between 2013 to 2015. So people were having more frequent testing. However, and similar to, I guess, what Joe presented, I'm sorry, that's the next slide. There was no change in actually the total number of gay men who had at least one annual test. And the other thing we weren't doing so well, which is what Joe presented, similar data from New Zealand, was that there was reducing condom use for anal sex, and that had been gradually creeping up. And was the highest proportion in the gay community periodic survey in Australia, with over 40% reporting any condomless anal sex in the 6 months prior to the survey. So basically, what we're doing without PrEP was we're having stable HIV notifications, showing that the current prevention mix that we're using was simply not enough. So you've spoken about your PrEP demonstration projects, and Sunita mentioned that the NZ demonstration project is based on the Prelude study that I was involved with in New South Wales. There was other smaller projects in Victoria and Queensland. And really the important lessons that we learned from those projects, those smaller demonstration projects, was that PrEP very, very quickly attracted high-risk men. There was very high levels of adherence to PrEP, and that was not only by self-report, but proven by biological testing at 6 months and 12-month follow-up. Very high rates of STIs, which we've just heard about from your group as well. At the 9-month follow-up in the Prelude study, 1/3 of all of the men had either gonorrhea, chlamydia, syphilis, or multiple infections. So very high rates of STIs. But the good news, although it wasn't powered to show efficacy, was that there was no HIV seroconversion seen in around 500 person-years of follow-up. So with the HIV prevalence in Australian gay and bisexual men 50 to 150 times higher than the general population, we knew that the biggest bang for buck was by first targeting the highest risk HIV positive gay and bisexual men. And this mathematical modelling was done by my colleague, Dr. Richard Gray at the Kirby Institute. And really what that showed was that we had to get 90% of high-risk gay and bisexual men on PrEP as quickly as we possibly could. We found from that mathematical modelling that lower levels of rollout led to much lower reductions in the incidence of HIV, and that similar to vaccinating large populations, herd protection is a critical part of the population effect, because if you're having sex with someone on PrEP who's not got HIV because they're on PrEP, then you're not likely to get it even if you're not taking PrEP yourself. So again, these were the similar risk criteria Sunita just showed, and I'm not going to go through these. These were derived from the Health in Men cohort study that we carried out in Sydney about 10 or 15 years ago. And although the overall incidence in gay men was only 1% per year, all of those behavioural or risk markers and STI markers were associated with significantly higher risk of HIV. So that was why we targeted people with those reporting those factors. We then had to obviously educate the community, build demand. So this was a poster which was actually in my local train station, believe it or not, about PrEP. We had community forums similar to what you're doing here. We had ACON very strongly, our peak body in New South Wales, very strongly promoting and supporting that. This is them on the Gay Mardi Gras, promoting PrEP. And we also made to make sure that it was being distributed to all high-risk gay men, not just those who could speak English, had translation of all the PrEP pamphlets into some main languages spoken in Australia. So the EPIC New South Wales was basically the expansion of the Prelude study, and the key design features was that because it wasn't, because PrEP wasn't approved for use, we had to do it within a clinical trial framework. It was carried out statewide, or is being carried out statewide, both public and private clinics, and the initial aim was all high-risk gay and bisexual men on PrEP by the end of 2016, and that was estimated at that point to be 3,700 men over a 10-month period, which was a huge ask. Then subsequently, and to our distress, because we didn't actually get paid any extra money for doing this, they said we wanted to do 8,000 men, and now they're even saying maybe there might not be a cap on it at all. Relatively simple for clinics. The toxicity outcomes collected through medical record systems and automatically downloaded, and primary outcomes, HIV incidence in the cohort, and newly acquired diagnoses in the state. So those are just all the sites, both private, mainly around Sydney, where the bulk of the HIV epidemic is in New South Wales, but as far north and as Byron Bay and out to Wagga Wagga and some of the country areas. So the challenges, I thought this was really useful for you guys, because I know you, especially you who work in public sexual health clinics, are under the same kind of pressure as we are with lack of funding, even cutting of fundings. So the challenges were, for us, that it had to be done with a clinical trial framework, because PrEP hadn't been approved by the PBS, so it had the same kind of approvals as you've got. It had gone through PBAC, but the PBS is the one who says, yes, the government will reimburse or support this to make it affordable. The targets dictated by the health department for us were 500 enrolments, and we started a bit later. So that was going to be 500 enrolments within 7 months. And the targets were very sneakily made a tier 2 key performance indicator for all the CEs of the local health district. So we were under the microscope. And as I said, no additional funding for New South Wales Health. Well, I'm lying. They said if we made 500 by the end of the year, they would give us $20,000. How kind of them. The other problem was that the pharmacy wasn't getting paid either, so they weren't willing to dispense it, so we had to dispense it in-house at the clinic, and we had limited staff. And unlike general practitioners, where they could actually employ additional people to do additional sessions and bill Medicare for that, we didn't have the money to employ any more staff. So the challenges for our clinic was that this was our occasions of service, face-to-face, that over the previous 5 years before starting PrEP, we had almost had a 50% increase in face-to-face consultations, and that was without PrEP being available at all. we clearly needed to plan carefully the number of PrEP consultations, and remember these are all face-to-face consultations needing to be seen each week. And we did this simply by just mapping it out. And you can see there were months where we were having enrollment visits, and then we would have to see people at a month, 3 months, 6 months, and 9 months. So we're having to see an extra 100 face-to-face consultations each week. So we developed a pretty novel mode of service delivery, which has not been used by any other clinics, but I thought I wanted to share this with you because it might be something that you find useful. First of all, we got ethics approval for doing group education sessions, which significantly cut down the clinician face-to-face time. So we had up to 20 participants. We did start off with just 2 or 3 a week, just to try and slowly see how things went for the first 2 or 3 weeks, but then rapidly expanded to 20 participants a week. That group session took 45 minutes and was led by our PrEP nurse coordinator. Obviously, we did offer the option for one-on-one consent, but really the vast majority of men who were wanting to enroll agreed to the group session, and any further questions were then able to be answered during the consent signing with the consult, the clinician and the consult after the session. So that really cut down a huge amount of consult time. We then decided we were going to have designated PrEP clinics, and it was really run like a production line. At those clinics, we were very clear that we were not doing vaccinations, treatments, or any other management. It was purely PrEP. If they needed anything else, they had to come back for another visit. We had 5 clinic rooms running, and we had 15 minutes appointments, and we had basically booked them all up solidly using all our available clinic rooms. So in general, we tried to assess the eligibility before we booked them in. So one of our nurses or our counsellor would assess eligibility on the phone. Then they would subsequently have their formal eligibility assessed at the clinic. They would then have the group education session. We then had 2 nurses dedicated to 2 clinic rooms, just doing bloods and STI testing. They were then moved to the waiting room and literally moved up the production line. And then the next waiting was taken into the consult room by the next available clinician when they were finished with the previous patient. The participant then left with their PrEP and results. They were told not to start until they had an SMS the next day with their HIV negative result, and then any other results where they were called and recalled into the clinic to be managed, like positive STI results. Staffing, we had 1 medical officer prior to the clinic starting for 2 to 3 hours actually prescribing all the PrEP. We then, very importantly and successfully, have worked closely with ACON and used peers at each of our clinics. They welcome participants, they perform the formal eligibility assessments, and they instruct on self-collection of STI specimens. There was a marshal to move participants through the production line. I'm not kidding you, we had to do this really, really tightly. We had a clinician in separate offices we had 1 clinician in a separate office who was dispensing and logging all the PrEP given out because it was a clinical trial. We had 2 RNs on blood collection duties only, and we had 5 clinicians seeing participants for assessment and dispensing. So then, what's that done to our numbers? Well, we have had a 60% increase in the last year in face-to-face consultations at the clinic, and it's been bloody hard work, and at some points really quite demoralizing for the staff because it really doesn't take a lot of skills to do this, but I think they realized they had buy-in and realized how important it was that we were involved in this study. So is PrEP working at a population level? And Sunita, I think you stole my thunder earlier, thank you, in my slide. So throughout New South Wales, we've had, by about a couple of weeks ago, almost 7,000 men enrolled, or not just men, but high risk, but mainly HIV negative gay men. And the great news story is in the first half of 2017, we've seen the number of new diagnoses at the lowest level since HIV surveillance began at the beginning of the HIV epidemic. So that's pretty amazing. And also, almost half of new diagnoses had evidence of early stage infection, which was a reduction of about 40% on the average January to June count since 2011. So that was showing that people were testing much more regularly, and the HIV infection was being picked up early, which obviously will reduce transmissions in the community. But there are some people who are missing out on the HIV prevention revolution. So there was no change in those, the proportion of people who are diagnosed at late stages of HIV. There was no changes in people who are overseas born, gay and bisexual men, and in heterosexuals. Now, although the number of heterosexual diagnoses were very low, there was actually a 25% increase in heterosexuals. So we clearly need further efforts to reach untested people, especially in higher risk groups, and better identify people at risk, especially, I think, heterosexually identifying men who have sex with men and others from culturally and linguistically diverse backgrounds. So PrEP nationwide in Australia, there's been no seroconversions in EPIC so far. It continues to roll out. It's been extended to the Australian Capital Territory and WA. There's other large-scale rollout studies in Victoria, in South Australia and Queensland, which have recruited around 6,000 more participants. But clearly, true national rollout requires government subsidy. We did have an application for funding for the PBS last month. Unfortunately, it was turned down, much to our disappointment. We think probably they're just waiting for more data, and perhaps a full year of data showing continual declines. So possibly we'll aim for another submission in early 2018. So that's all I have to say. I'd just like to acknowledge Professor Andrew Gulick, the massive EPIC New South Wales study team, and Irina Zablocka, who led the Prelude study team. Thank you.